Good evening and welcome to Doctors on Call. I'm Dr. Mary Owen, Associate Dean of Native American Health and Director of the Center for American Indian and Minority Health at the University of Minnesota Medical School. I'm also a family physician for the Fond du Lac Band of Lake Superior, Chippewa. I'm your host for our program tonight on lower GI problems. The success of this program is very dependent on you, the viewer, so please call in your questions or email them to ask@pbsnorth.org. The telephone numbers can be found at the bottom of your screen. Our panelists this evening include Dr. Joe Bianco, a family physician with Essentia Health Ely and faculty member at the Medical School Duluth, Dr. Jonathan Gapp, a gastroenterologist with Essentia Health, and Dr. Paul Sanford, an internal medicine specialist with St. Luke's Internal Medicine Associates. Our medical students answering the phones tonight are Claire Buntrock from Rochester, Minnesota, Katie Benson of Staples, Minnesota, and Tommy Gentle from Baudette, Minnesota. And now on to tonight's program on lower GI problems. Well, thanks for being here.
Thank you for having us. Nice to see you.
We did get an early question, so I will ask, how about we start with you, Dr. Sanford. Is there any evidence that small intestinal bacterial overgrowth can be cured?
Yeah, no, it can be. When you get too much of a good thing, the bacteria lining the bowel and shellacking it, it can be brought under control with certain antibiotics, rifaximin, but it can come back. So,
What is SIBO? What does that mean? What is the bacterial overgrowth? Why do you get that?
Well, I'm not sure why. Dr. Gapp probably knows more about it than I do, but it's just an opportunistic bacteria that overgrows the normal flora.
Yeah, normally most of the bacteria in your gut is in the colon. That's where it is predominantly, especially for folks who might have had previous surgeries. You can get that bacteria kind of creeping back up into the small bowel, where it's not. There's usually a lower amount of bacteria, and then that can lead to things like fermentation and a lot of gas, bloating, and discomfort. Just because now you've got this 25 to 30 feet of small bowel with bacteria fermenting and causing those problems.
Now, bacteria can be a normal part of our bowel.
Oh,
correct?
yes.
They're a critical part of the bowel.
They're important hitchhikers that help us digest foods and fibers.
Mm-hmm. And they're part of this microbiome that we keep hearing about.
Yeah,
Right.
critical part.
Some people think it's an organ in and of itself.
Okay.
Our small bowels and our large colon, or large intestine, the bacteria is critical for our immune system.
Mm-hmm.
And they are critical for the lining of the bowel, which in a sense protects us from a lot of other different kinds of inflammatory types of diseases. Those millions and millions of different types of bacteria, there's not just one, but there's many, many different kinds that are just a part of our bowels. And from the time that we're born is when they're first introduced, and oftentimes your own microbiome is very much similar to what your mother's was. There's some correlation there.
But not always. We've seen twins where they can sometimes have a different microbiome of the gut.
Right, exactly.
Yeah. Dr. Gapp, what do you tell your patients if they ask, how do I keep a healthy microbiome?
Mm-hmm. There's some data, or mostly people's questions tend to be about probiotics, I would say. Should I take a probiotic? Mm-hmm. As far as how do I keep a healthy microbiome? I would say there's not a lot of data on how to best do that. Is there one probiotic or prebiotic that might be better than another one? So normally I say something that's cost effective. Because there's not good data, choose something that's not going to break the bank for you. So I know some patients are using their yogurt with live cultures, and other folks are kind of buying the over-the-counter supplements to supplement their bacterial flora.
Anything to add to that, Dr. Sanford or Dr. Bianco?
Just my Uncle Sven, who's 100 years old, loves his kefir, but he puts it on pickled herring, which is disgusting.
And I don't know if kefir is the deal, but I do know that people do talk about prebiotics, and that is, plant-based diets, fresh fruits and vegetables, that type of thing. Those have been shown to help promote a good, healthy microbiome, and so I think that's really important as well.
Dr. Gapp, what are some common causes of diarrhea?
Well, antibiotic-associated diarrhea is one that kind of leads off of what we were just talking about. So sometimes if you take an antibiotic and it kind of clears out the flora that has been there, then essentially that leads to diarrhea because you no longer have that flora there that was kind of modulating the gut there. Or that can just be as a result of a side effect of the antibiotics that you're taking. Other things that we hear about are things like Crohn's disease or ulcerative colitis, and these are inflammatory bowel diseases. Also still kind of finding out, why it is these occur, but in some cases there seems to be an autoimmune component, but also there's a question as to, does this also have to do with the microbiome as well? How your gut immune system is reacting to having certain bacteria in the bowel. And so that's inflammatory bowel disease, which can also cause diarrhea as well. And if you're talking about GI problems, irritable bowel syndrome and diarrhea as well, which is kind of a more functional cause, so almost like the way that the gut and the brain are talking to each other, and some of these folks are having frequent bowel movements that almost seem to be tied to things like their anxiety levels or other aspects to how the gut is controlled by the neurons there.
So the treatment then would depend on whichever the cause was.
Right, yes, for sure. Yep,
okay.
Yeah. You treat an inflammatory bowel disease very different than you treat something like small intestinal bacterial overgrowth, which can also cause diarrhea. Other causes of diarrhea can be the sugars that we drink. So sometimes if you're getting drinking a lot of diet soda, that can draw water into the gut, and that can lead to pulling more water through the whole GI tract, and that leads to diarrhea as well. So you treat that by recommending, hold off on the diet soda a bit, or hold off on the artificial sweeteners.
And there are certain meds too. I think one of the common meds is for folks with diabetes. Metformin or glucophage is another one that is common ones. And there's a number of other meds that can do it as well.
But even though that medication can cause that, your doctors can do things to taper it or slow down because some of those medications are so important, like metformin.
Exactly. So it's just kind of a balance. And again, diarrhea is a degree. I mean, what is diarrhea? I mean, for some people, it's variable for what one person thinks their stools are abnormal versus what one would consider to be abnormal.
Right.
And in a resource-rich country like ours versus the rest of the world, where diarrhea is one of the major causes of mortality across the world, I mean, we have a kind of a different perspective sometimes on this and what causes it. And in the vast majority of the world, it's it's a public health issue because of sanitation and food sources that are the major causes of diarrhea in those places.
All right, we do have another question. Dr. Sanford, what's a hernia and when should you get surgery for a hernia?
Wow. Well, a hernia is any time that a piece of bowel or internal structure goes through a natural boundary that it shouldn't. So you can have a hernia where the intestine pushes out by your belly button or in the groin. You can have a hiatal hernia where the stomach is starting to rise up into the chest. Diaphragmatic hernia, where sometimes a loop of bowel will go right through the diaphragm that separates the lungs from the belly. Yeah, it's just a violation of a boundary. And sometimes you fix them, sometimes you don't, depending on what type of a hernia.
When should you call your doctor about them?
If you have any alteration in bowel, bladder, fevers, chills, pain, if it pops out and you can't reduce it, push it back in, then it's a good idea to talk with somebody before it turns gangrene.
Okay, but the pain's a big indicator. If you're having a lot of pain, then you got to see somebody.
That's right.
Definitely. Okay, anything to add to that, gentlemen? Doctors?
No, I think he covered it.
No,
Okay.
I agree with that.
Good. Did something right.
Okay, Dr. Bianco,
Yes.
leaky gut. What is it and how can it be treated? This is a question from Duluth.
Leaky gut. Well, so I'm not exactly sure what leaky gut is. I'm thinking if it's incontinence. You know,
that would make sense.
incontinence would be that through the anus you're not able to control your stool. Sometimes that has to do with what the stool is like. If somebody has diarrhea, sometimes it's hard to control that, but there are other reasons why people can have incontinence of bowel. It could be neurologic, with certain neurologic problems and spine injuries. That type of thing can lead to that. Previous surgeries. There could be a mass down there that could affect the ability for you to be able to retain your stool and control your stool. So I think that's what they might be referring to. I don't know. Do you know anything if that term leaky gut refers to anything else?
I think sometimes I hear it used different ways, so
Yeah.
I think I would agree with what you're saying
Okay,
there, actually.
okay.
Yeah.
Yeah.
And it's rare to get a fistula or,
Yeah.
but people keep forgetting that the internal anal sphincter is the smartest muscle in our body. It's the only one that can tell the difference between a liquid, a gas, and a solid.
Right.
Never thought about it that way.
Yeah.
All right, Dr. Sanford, you're on. Someone has chronic diarrhea and was prescribed Xifaxan for treatment. Is this a medication that would be needed to be taken indefinitely?
Yeah, well, again, I think if they mean rifaximin, but yeah, it's something that usually for 2 weeks or so you take if you're concerned about a bowel overgrowth situation, but it's not something you take forever at all.
Okay.
And it's FDA approved rifaximin for IBS-D, so I think that's what a lot of folks are actually taking it for rather than small intestinal bacterial overgrowth. And actually you would be taking it for just that 2-week course, and then hopefully things go back to normal if you're treating IBS-D, and then they can come back if they have recurrence a few months later, and you can retreat. So yes, you may need retreatments, but you're not going to be at every day indefinitely. That's kind of what I had to say.
Yeah, well, amen.
Okay, Dr. Bianco. I eat 3 meals a day, but often get a stomach ache if I eat between meals. Why might this be?
Get a stomach ache if I eat between meals?
Yep.
I'm not
Anybody?
sure why
Guilt.
that would be.
Guilt.
People, I mean, so stomach aches, okay, just basically talking about stomach aches, especially if it's occurring in the upper part of the abdomen versus the lower part of the abdomen. Our bodies, after we eat, are naturally can have some increased peristalsis or squeezing in our bowels and in our colons. And so people can have increasing abdominal pain following that. When we are most likely to defecate or to go to the bathroom with a poop is going to be after we eat. And oftentimes in the morning, that's kind of like our cycle. That's the best time in the morning and usually after we eat. So you can get some cramping going on and uncomfortableness. So that might be interpreted in between meals when people are having that pain.
Good thought. Anybody else? Any other?
Yeah, I do find especially patients who are really struggling with constipation, kind of going with what you were saying, is that they'll eat, and then because of that peristalsis and because they have a colon that's full of a lot of hard stool, once they start kind of pushing against that from that gastrocolic reflex after they eat, that's when they start to have their pain. So, yeah.
And the other one, if it's more in the upper abdomen, if people are having problems with their gallbladder, and eating a fatty food, and then after you eat, your gallbladder is working to digest that food. But if the gallbladder isn't working properly, you can get pain from that for that reason.
Thank you. Dr. Sanford, what can you do about microlymphocytic inflammation of the bowel?
Microlymphocytic, I mean, is it referring to microcollagenous colitis or Clostridium difficile?
That's what I would guess.
Probably microscopic.
Microscopic colitis.
lymphocytic,
Yeah. It's an interesting condition where people get diarrhea, and it's usually, you have to help me. I've only treated one person with that. What do you use for it?
Yeah, normally there's kind of 2 routes that you can take. I mean, you can use a steroid-based treatment, so something like budesonide that just coats the bowel tract. So then it's not a steroid that's getting into your entire system, so you have less side effects. And that can kind of cool down that inflammation in the GI tract. But microscopic colitis, it's not normally a life-threatening disease, it's not a life-shortening disease, so even something like using loperamide just to slow the gut down, if it works, that's fine to use as well. So sometimes, normally what I'll do is I'll start with a steroid, like budesonide for about 8 weeks and taper it down and get them off of it, and then if they do okay, kind of let well enough alone and see how long that takes them. And if they need, some loperamide now and again, then that's the route I would go. But some patients do need to be on a low dose steroid like budesonide for long periods of time, depending on the severity of their disease.
Do you ever use sulfasalazine?
Not for microscopic colitis, I haven't. Yeah.
So with microscopic colitis and then inflammatory bowel diseases such as Crohn's disease or ulcerative colitis, are they in a continuum? Are there similarities? And I know so much more, and people are probably seeing this with advertisements on TV about the tumor necrosis factor inhibitor, alpha inhibitors that are out there. Are those being used for this type of problem as well?
Not normally. I have seen some cases of very severe microscopic colitis but normally that's more of an autoimmune enterocolitis, where we would maybe consider using something like a tumor necrosis factor inhibitor. We don't classically talk about kind of inflammatory bowel diseases being on the same spectrum as microscopic colitis. And normally microscopic colitis I find much more mild, easy to treat, and usually presents as more just ongoing watery. It can be severe watery diarrhea, whereas kind of classically the more inflammatory bowel disease is the bloody diarrhea.
But were you asking because they act almost like an autoimmune disease? Is that what you're asking?
Yeah, because of when we're getting back again to the microbiomes again and the breakdown of the immune mechanisms within the bowel itself. There's thought that with the inflammatory bowel disease, that's one of the factors that's going on with those.
And it's interesting. I mean, you use a steroid to decrease the inflammation, often commonly used with autoimmune diseases as well. But
But I still, most of the time when we're talking about microscopic colitis, we still try to blame a medication first. So something like an NSAID, like ibuprofen, or actually even SSRIs used for anxiety or depression are also some of the top causes of microscopic colitis.
But as you pointed out, Dr. Sanford, pretty rare.
Yeah, I've only had a couple people that have had it. But.
Yeah, okay. Dr. Sanford, can anal fissures be serious and cause cancer?
Ooh, the fissure itself wouldn't cause cancer. The fissure is just where you have a cleft in the anus that sometimes can be uncomfortable or can help with stool leakage because you have a interruption of the anal sphincter. I've never heard of it being associated with malignancy at all. Have you?
No, anal fissures, oftentimes people will have a large, really hard stool, and then they'll notice on their toilet paper some blood. Yeah. And they usually, if they're able to get their stool soft again, over a period of time by taking a high fiber laxative or something, not a high fiber laxative, something like that, getting their stool soft, it'll heal by itself as long as their stool doesn't get really large.
Or doing that boring thing that doctors talk about, like lots of fruits and vegetables.
Lots of fruits and vegetables, high fiber.
Yeah. Stop it, doctor.
Lots of water.
Yeah, lots
Don't
of
eat
water.
so many cheeseburgers.
Yeah, right, exactly.
Cheeseburgers.
Yeah.
Okay, Sue asks us, let's see, Dr. Gap, is there an upper age limit after which colonoscopies can be replaced with less invasive procedures such as Cologuard?
That really depends on the situation. So in all cases, we normally say, you can talk about, you should be getting your colonoscopy for screening or for polyp surveillance up until age 75. And then after that point, it's a conversation between you and your family doctor. How's the rest of your health? How much do you like getting colonoscopies? Is to decide, do you go another 10 years up to age 85? And then after that, it's kind of a hard cutoff. Don't tend to do them anymore for polyp surveillance or for screening. But whether or not you should be using a different method of screening in the first place, like this Cologuard, depends on if you have a family history of colon cancer, or if you have a family history of even what we call advanced adenoma, so certain polyps which are higher risk for causing colon cancer. If you've got that family history, then you shouldn't be using Cologuard in the first place.
Anything to add, Dr. Sanford?
Oh, I'm amen. Yeah, it's
Well, as long as we're on screening, this is our plea for people to get screened.
please.
Yeah,
And can you remind people what the Cologuard is?
Well, there's 3 ways to screen. The best screening tool is a colonoscopy,
Yep.
but people are reluctant because of the prep and that type of thing. But it really is the gold standard. And then there's Cologuard, which is a DNA-based test in which your entire stool is looked at, and looking at the DNA but it's not able to detect polyps, which are precancerous growths. And then there's the FIT test, which is just looking at some other factors within the stool itself. So you can do those other ones if people do not want to have a colonoscopy for whatever reason, but the bottom line is a colonoscopy would need to be done if the other 2 tests are positive.
Okay.
I think it's also helpful for patients to know that on colonoscopy, your ability to go in, see a polyp and remove it, kind of puts you one step ahead of the game.
Yes.
That polyp no longer has a chance to become a cancer. For the other tests, you're more, like you said, looking for cancer already, whereas in colonoscopy, oftentimes we can get way ahead of the game, remove those polyps.
Absolutely.
Yep.
And if you do have polyps, you're not a candidate. If you've had a colonoscopy, you've had polyps found, you're not a candidate for the other tests. You are now on the pathway of having colonoscopies.
Yeah.
That's a good
And
reminder.
Family history too. So.
Yes.
All right, Dr. Sanford, you talked about those yummy cheeseburgers, but going back to fiber, can you have too much fiber?
Boy, when you look at cultures, Indonesia, where the diet is so heavily high fiber, fruits, veggies. I don't think you can have too much fiber.
Okay.
I don't think it's possible.
Yeah.
And it's interesting in those cultures, you just don't see diverticulosis where you get little outpouchings in the colon. It's probably rare enough that every time they get a patient with diverticulosis or diverticulitis, they probably call every medical student in the country.
However, here we're seeing it at younger and younger ages in our
Yes.
own country,
Yes.
because of those cheeseburgers.
Cheeseburgers, white bread, Velveeta, the American diet. Eat your vegetables.
Back to diet. Go ahead, Dr. Gap. You were going to say something.
The only thing I was going to say about fiber is I agree, good for colon health, good for cardiovascular health, so it's a win-win. The only thing that you might run into is sometimes I'll ask patients to increase their fiber, whether it be dietary or supplemental, like psyllium husk. But sometimes they'll come back to me and they'll say, "Boy, doctor, I got a lot of bloating when I tried to change my diet. Now I'm having a lot of belly pain after I eat." And then normally the recommendation is to find the fiber that works for you. You can try a couple different sources of fiber, or just scale it up really slow. And if you take it easy, increase your dose of fiber over a couple of weeks, a lot of patients do a lot better.
And augment that with a lot of water.
Water.
Amen.
A lot of water. 'Cause
Water
a lot
is
of water
essential.
Water is essential for good colon health and good regularity of stools.
Okay, I think they're going to tell us we got 30 seconds in about 30 seconds. So let me try this though. Dr. Gap, what is the best diet for someone with diverticulitis and gastroenteritis?
For
30-second question.
osis,
No.
diverticulosis, or itis?
Itis.
Itis.
Yeah.
I would say high fiber is all you can do, and then you can treat the diverticulitis with antibiotics if needed.
Okay. I was just teasing you about the 30 seconds.
Oh, okay.
So now we got to fit in another one for 30 seconds.
Oh my gosh.
Is there anything else that we would like to cover? Make sure that our audience knows, our people at home know. We covered lots of fruits and vegetables, lots of water. Get your colonoscopy. Anything else?
No, just a happy colon is what we all want.
Okay.
Yeah.
Is there a topic that you feel like we should have covered?
I don't think so.
Well, I think that it's a broad area,
Yeah.
but any kind of abdominal pain, any change of stool needs to be evaluated.
Bleeding.
Bleeding.
Yeah,
Yep.
bleeding
Needs
is
to-
certainly
yeah,
going
it
for.
needs to be evaluated.
Okay. All right. I want to thank our panelists, Dr. Joe Bianco, Dr. Jonathan Gapp, and Dr. Paul Sanford, and our medical student volunteers, Katie Benson, Claire Buntrock, and Tommy Gentle. Next week, please join psychotherapist Dina Klebaugh for a special mental health edition of our program on PTSD and trauma. Thank you for watching, and good night.